I am really excited to have her talk about advanced maternal age and fertility. And I know we're going to go and have some great conversation today. I know we get a lot of women in my prenatal program as well, like in their mid 30s and beyond, having babies. And so I'm really happy and excited, Dr. Shannon, for you to help clear up some of the questions that we get. So
Well, thank you for having me. Mhm.
So let's go ahead and get started. Like, what are
Mhm.
some of those biggest myths, surrounding the advanced maternal age? And do you want to explain what is classified as
Mhm.
advanced maternal age?
So advanced maternal age is traditionally being referred to, has always been referred to as being age 35 and older. So that means if you're turned 35 throughout the course of your pregnancy, that you will be labeled, and it's a label, diagnosed with, if you will, as being advanced maternal age uh, for medical purposes, even if you get pregnant at 34 and then subsequently turn 35. And that's just based on what the traditional risk of having a pregnancy after 35 and especially after age 40 are in that age group. And you could start with just the problems with becoming pregnant, potential issues with fertility in general. And I won't go into that. I'm not a fertility specialist, but I think pretty much everyone knows by now that egg quality and quantity decrease with age, but it's not the same rate or the same time. It doesn't occur at the same time for everyone. And there is an increased risk of pregnancy loss once someone does become pregnant. And most of those pregnancy losses, especially over age 40, are going to be due to chromosomal abnormalities. Once you get past that hurdle, if you will, there are some complications with pregnancy just based on age alone. That's going to be preterm labor and delivery, abruption, potential for cesarean delivery when you deliver, placental implantation abnormalities, gestational diabetes, high blood pressure, preeclampsia, or hypertensive disorders of pregnancy. So even if you come into the pregnancy perfectly healthy 39-year-old, you're still going to be at increased risk just based on age alone. Yeah, so if you also consider with the potential complications of having a genetic abnormality in the fetus, that antenatal screening that's offered anywhere up to 20 weeks, and there's various forms of antenatal screening that we can do. That's really recommended in those over age 35 and especially over age 40, just to see what the risk is. It doesn't mean any decisions have to be made based on that, but it's very helpful if at the time of the anatomy scan at 18 to 22 weeks, when that's typically done, if there is an abnormality, it's much easier to put it into context as far as what the risk might be if we do have that antenatal screening. So those are just some of the reasons why, after age 35 is considered high risk because it's advanced maternal age. But there's a quote that I heard, and I don't remember where, so I can't take credit for it, but regarding this topic, I read that just because your pregnancy is high risk doesn't mean your risk is high. It's going to be different for everyone. Yes, you're going to be considered high risk because of your age, but if you're otherwise healthy, then that's going to mitigate your risk to some degree. So it doesn't necessarily mean you're going to have a bad outcome or complications or a terrible delivery or anything else like that. It's just something that we need to know as your provider, what you're at increased risk for based on your age. And then also if there's any other complications that you come into the pregnancy with, we definitely have to pay extra close attention to that. So I want to kind of dispel the myth that every pregnancy after age 35 and 40 is doomed. It's not. We have plenty of healthy pregnancies, but we also have those that aren't. And a lot of them, it can be due because of the age factor. So we just have to be realistic. We have to be informed. We have to be empowered to understand what could happen in the pregnancy and act accordingly, and work with our docs, with whoever your doc is, to help minimize those risks as much as possible.
So can you share what some of those things that our moms can be doing to help
Mm-hmm.
to mitigate those risks?
Well, I think the most important thing is, as we age, just in general, we do start to develop certain medical conditions. So if you do have any kind of chronic medical condition, especially if it's being controlled with a medication, that you are optimally controlled on that medication, or that condition is optimally controlled. Because if you get pregnant and you're not controlled, that makes it that much harder to start playing catch up, especially at that, if you are of an advancing age. So the first thing I would say, if you have any pre-existing medical conditions, make sure they're as well controlled as possible before conception, if we can. The other thing would be, maintaining a healthy weight and a healthy lifestyle as much as possible. That's not only going to help with the pregnancy, but could potentially help with your fertility as well. So, getting all your baseline health screenings done, being up to date on that, maintaining, like I said, a healthy weight and a healthy diet is important. When you start thinking about fertility and you're already kind of potentially behind the 8 ball, if you will, based on age, make sure you're not doing anything that could also further impact your fertility, like smoking, things like that could also affect your fertility. So, there are things that we can do. Make sure we're taking a prenatal vitamin while we're trying to conceive. It's important. So there are certain things that we can do to try to get us started on the right foot once we do become pregnant.
Yeah. And I know it's, optimal, right? But we don't live in this optimal, perfect world all the time to be able to do what we can before we get pregnant. But once she does get pregnant and finds out, like even changing her habits as soon as possible so that she is healthier can have a huge, profound effect on
Exactly.
her health and baby's health and how her pregnancy goes and all that. So okay, so I wanted to ask you some questions that we get asked in our prenatal program as well. So what are your thoughts on the 39-week induction? Is that something you support? It's something that's been, my youngest is 9.5. So it's been a while since I've been through this personally myself, and there's always new information coming out, but we're hearing from a lot of moms and particular, whether they're of the advanced maternal age or not, really encouraging inductions around 39 weeks. I don't know if you can speak more to that. Is it good? Is it bad? Is it just depends on the pregnancy, right?
Yeah, no, I firmly support everyone being offered and counseled about an elective induction at 39 weeks. And that really changed back in 2018 when the RCT called the ARRIVE trial was published in the New England Journal of Medicine. So basically they looked at otherwise low risk first-time parents or pregnant persons who were getting electively induced at 39 weeks versus going into expectant management and then spontaneous labor on their own. And they found two main things. Number one, the risk of cesarean delivery is lower in those that underwent induction of labor, and the risk of hypertensive disorders of pregnancy was lower. Now, that's in what we call nulliparous or first-time pregnant persons that are otherwise uncomplicated. But we can extrapolate, right? If you have someone that's complicated, already with diabetes, high blood pressure, other complications, then obviously that could apply to them as well, whether they're a first-time parent or not. So it was a good, especially to see in a nulliparous patient, that it didn't increase the risk or rate of cesarean delivery, which was a commonly held belief, at least by those that weren't obstetrical care providers. We kind of knew it, but we definitely had to have the evidence from this ARRIVE trial, which where I work, we participated in that trial. So yes, I am 100%. I do endorse where I practice. We offer it to everyone. It doesn't mean everyone has to do it. Sometimes patients need to be based on their comorbid conditions or things that are going on in their pregnancy. But I am a believer in, if you will, and I do support the elective induction being offered at 39 weeks.
Do you see that a good amount of moms take you up on that offer? Or
absolutely, yes.
Yeah,
but it's also my patient population as well. We have patients that live far away, so having a scheduled induction and knowing when they come in, rather than potentially, and it also depends on your patient population. Of course, I have a high risk patient population. A lot of them live far away, so having an induction scheduled at 39 weeks is ideal for them. Okay. So but it doesn't mean you have to. And that's something you can talk to your obstetrical care provider as you start to get further along. What are their typical practices regarding induction? Some providers offer induction to all their patients. Some don't. But you can discuss it with your obstetrical care provider to see what your options are.
Okay. Yeah. Thank you for clarifying that. So, and I know because you work with women, who are pregnant 35 and up, and because they are, quote, classified high risk, but like you said, that doesn't mean that they are, that there's really a lot different that they necessarily be doing. It's just an age thing. So when it comes to exercising, which is something I'm a big fan of and encouraging moms to stay active, but not just that, addressing pelvic floor, deep core function, all that. But what do you recommend to your, let's first say, like the healthy, moms who are, 35 and up, during pregnancy?
So, I mean, the general rule of thumb, and this applies to everyone, not just those over age 35 or 40. Whatever exercise routine your body is accustomed to before you got pregnant and what you're conditioned to do physically, you can continue for as long as you can into your pregnancy. Of course, things might change as your, belly gets bigger and you get further along in the pregnancy. Your balance can get a little off kilter when you're getting further along. Your belly might be in the way of some of the normal activities you were used to. So as long as you're willing to make adjustments throughout the course of your pregnancy, you can continue the same exercise routine. The only exception would be is if your previous exercise routine included some kind of exercise that would increase your risk of abdominal trauma. Obviously, if you're a competitive biker and you're 39 weeks on a speed bike, I would not recommend that. Or I'm going to tell you to do a stationary bike. I mean, there's things that you can do. Or if you're, someone that goes to CrossFit, and I support CrossFit, it's fine. But, doing some of the exercises where you could potentially hit your belly. And I'm not picking on CrossFit. It's just an example. You may not want to do that. You might want to do something else instead. So you definitely want to be conscientious about any direct abdominal trauma or anything that might cause you to fall, or anything like that could, especially as you get further along, that could injure, cause you to injure your abdomen. So that's for those that have a pre-existing, exercise regimen. Keep it up, hydrate, pay attention to your body. If you feel like taking a break, take a break. If you feel like not working out that day, don't work out that day. I think those that have a very set exercise routine, it's very hard for them not to continue exercise, and they feel guilty and they feel, I don't want anybody to feel that way. It's, you got to listen to your body. You got to do what you feel like doing, even if you were going to the gym 5 days a week before that. For those who don't have an established routine, it's not the time to start going to CrossFit. It's not the time to start, doing Peloton. But you can do some, light weightlifting or some, stretching exercises, walking, getting that 30 minutes a day, 5 days a week at least is ideal for those that don't have or not, accustomed to an exercise routine. And then there's all those, most of the people will fall in the middle somewhere, and in which case you would just do whatever, you're used to doing.
So I have a more specific question, and that is around women who have had IVF and exercise. And I've worked with those women, right? And so typically those first, the first trimester, and tell me if something's changed, that we've told these women to, really pretty much be pretty sedentary. And I don't know, is that all still old information?
No, I
ask you because I want.
It's not a recommendation. The difference between IVF mainly and spontaneously conceived pregnancy is just how it was conceived. So once the pregnancy's up and going, there's not a not a real difference. There are some potential complications associated with IVF and further along in the pregnancy, but there's no reason not to exercise unless your reproductive specialist has told you for whatever reason. I'm not going to go against that, but there's nothing that I've ever read that said an IVF patient needs to stop all activity or most of their activity in the first trimester. That's simply not true. I think what it could be, it's the more of the psychological component of it, and the fear, especially when someone's probably had to go through a lot to get pregnant. They don't want to do anything that could potentially cause something, because if you did, then you're going to blame what you did. But there's really no data that says that you have to restrain or, withhold being physically active just because it's an IVF pregnancy. If it's better for you mentally, psychologically to kind of back off for a little bit, then you got to do what you got to do. But there's no physical reason why you can't.
Yeah. And I've worked with women who really have a hard time if they've been told to do next to nothing, because when they're used to moving their body, it's a stress release, right? And we know stress, and I'm happy for you to chime in on this, right? And I am always promoting to my moms, like really, really don't stress yourself out about decreasing stress, right? But be aware and cognizant of stress, because it can affect, mom and baby. And so really trying to minimize stress. So do you have anything else to add to that as well?
No, I did a post the other day about not, and I got a lot of crap about it, but about not, bed rest or activity restriction is not recommended to prevent preterm birth. And it's not. The potential downfall or adverse consequences of that are much greater than any potential benefit. None of the data has shown that, activity restriction is going to prevent adverse pregnancy outcomes. Now, you might modify things based on what your clinical situation is, but no body should be told you have to be in bed, you can't do anything for this period of time. That's not healthy in pregnancy, no matter what the indication is. So if someone's telling you that, you got to ask why. Well, what can I do then? Because there should be things that you can do and get that set away, because I know firsthand as being high risk that it's myself, and then also the patients I have, that, it's not beneficial for anyone to be strictly on bed rest. So that's what I have to say. And yes, of course, it does contribute to your stress. It contributes to your stress if you were active, but if you're not active and then you're told to not be even more active, that's stressful too.
Yeah, no, I appreciate you speaking to that, because I get women that will reach out or they'll be in my program and then they're like, okay, well, they're 36 weeks or whatever. And they're like, okay, my doctor's told me I got to go on bed rest. And I love hearing you say that, because it comes down to, like, when we talk about exercise, right? That's such a broad term.
Yeah.
And I like to look at it and talk more about movement, which those who have listened to me for a long time know that I love the term, just moving your body. And it can be so gentle, and just that little bit of, gentle movement can be so good for you for so many reasons, psychologically being one of them. But, just blood flow and just getting what's helping you, and so I really am, grateful to hear you as a physician who works, with women 35 and up saying that, because I will be passing that along.
Yeah.
Obviously I know, we have to listen to our physicians, but I love the question of, well, then go back and ask why, or what can I do? Even if it's like, I go outside and walk a little bit. I know with one of mine, my third, I think she put me on, it was like what they call modified bed rest. I think I had a big cyst or something at the beginning. And so I couldn't even walk my kids to the park and all that stuff. And it was so hard because you have two other kids and you're trying to I remember it was really tough. Thankfully it wasn't for very long, but So anyway, thank you for speaking.
Yeah, you're welcome.
Okay, let's talk about weight gain and pregnancy, shall we? We get these next two questions a lot, so we'll start with the one. So what is your advice to moms who are afraid of gaining weight during pregnancy?
So, you got to think, to make a baby, you have to gain weight. You have to. If you're starting out at an otherwise normal weight, it's healthy to gain weight. We have the uterus that's going to gain weight. We have the amniotic fluid to consider, the baby, the placenta, all of that weighs or will add to your weight. So, I'm not sure what particular type of, patient you're talking about, but for those that are at an otherwise healthy weight, gaining weight is fine. Now, obviously there are certain complications with excessive weight gain, and we don't want that. But, we do have recommendations as far as what the recommended weight gain is based on BMI. And although BMI is not the optimal measurement to use, just doing weight as far as pounds or kilos is not optimal either. We do need to find a better way to assess weight, because it's not really appropriate for all body types. So I am acknowledging that. But for now, that's the best that we got. So we do use the BMI. For those that are overweight, and that's when you start thinking about those that are BMI of 35 and 40 and above, it is not necessary, especially in those first several months of pregnancy, to gain weight, because you're starting at a higher weight and the baby will get what it needs. But there's a commonly held belief that even those of a higher BMI or a higher pre-pregnancy weight, that they do need to gain weight on top of that. And that's simply not true. So if there's any question, based on what your weight is and where you fall, just have a conversation or even see a nutritionist. We underutilize nutritionists for weight gain recommendations and, dietary recommendations for those more at the end of either end of the spectrum, those that are starting at a much lower weight than is ideal versus those that are starting on a higher weight than is ideal. Having nutrition on board is helpful. For most of those that fall in the middle, just be cognizant, excessive weight gain, whether we like it or not, is going to increase your risk of diabetes, having a bigger baby, having hypertensive disorders of pregnancy. There are complications with that. But that being said, for any obstetrical care providers who are listening, we have to stop with the shaming of patients when they gain excess weight and assume it's something they're doing wrong. Some people just gain weight and they're not trying. It doesn't mean they're eating Twinkies every night. And I feel that that's, some of the patients are, and some of them aren't, you know, and some people, no matter what they're doing, they gain a lot of weight. And I've known some of those patients myself. And the only way we're going to figure that out is we sit down with them, ask them what they're eating, you know, and talk to them, and they get really stressed out about it. And, you know, sometimes it just is what it is. And we have to watch out for that and do what we need to do for those that are gaining excess weight. Just, you're going to alienate your patient if you just start off by assuming they're doing something wrong, if they start gaining too much weight, or what you think is too much weight. And we have to stop taking that approach. It's not appropriate. It's not helpful for the physician-patient relationship. And it's definitely not helpful for the person that's on the receiving end of that. There's a way we could talk to them, especially those who are gaining at a faster pace than we'd like to see, to have a conversation with them about what they can do. But just telling them they're doing a bad job is not the way to do it. So the weight topic, especially in pregnancy, is a very, very sensitive one. We have to respect that, because I don't know very many pregnant patients who aren't worried about that. And to have their physician not be supportive makes it even worse. So, you know, we just need to take the patient as a whole, look at what their social circumstances. I've had patients who were in a situation to where they were working 2 and 3 jobs, and the only food they had access to was fast food, and they were doing the best they could with what they had. And what am I going to do? I can't go home and feed them. I mean, they're trying to support their other kids, and we have to look at the whole picture of why they're where they're at when it comes to weight gain. So I know that probably went on a little bit further than you were expecting, but you know, there's so many different aspects to the whole weight issue in pregnancy. And I feel like it's so much easier for us to say, you're gaining too much weight, you need to stop, than figuring out why or what's going on, or that maybe they're not doing anything wrong and it's just how their body responds to pregnancy. So we just need to be a little bit more, I don't know what the right word is, nicer, maybe that's the right word.
That's a great word.
When it comes to talking to our patients about that, and a little more understanding, take more time. I can't imagine, you know, I have talked to patients and I've been direct with them, but I can be direct and tell them about my concerns without making them feel bad. At least they know it's because I'm concerned and what the consequences are. But, you know, there's a way to do it and still maintain that relationship with your patient.
Yeah, you said so many great things there. And I just want to reiterate too, because this is a common thing that I hear from students is that, you know, they've gone to their doctor and maybe they didn't really gain much weight that first trimester because they didn't feel good, right? That can be a common thing. But then all of a sudden, baby starts to grow a lot in the second trimester. So all of a sudden she'll have a huge growth spurt and she'll gain a good chunk of weight over a handful of weeks. And she goes to the doctor and the doctor's like, oh, wow, you gained 5 pounds in the last 2 weeks, 3 weeks. And it's like shame upon her. And then she feels guilty. But it's like, but you have to look at the whole picture. So
the whole picture,
listening, you have to remember, like, and it's your body, you are in control, you know, and again, ask those deeper questions as to why, and why would the doctor be concerned if you've only gained total, right? Versus, oh my gosh, you have these little growth spurts where it's very common. And I know you see that.
It's very common for people that have nausea and vomiting in pregnancy, or even hyperemesis, and those that lose weight. Once they get better, and these are for the ones that do, you know, there's that percentage of patients that have it their whole pregnancy, and there are, but those for the ones that do get on the other side of it, they will gain, I've seen them gain 10 pounds in between visits because they can eat now and they're making up for lost time. I'm not going to fault them for that. I would be making up for lost time too. You were spent, 4 months picking your guts up. So, and they do have a little catching up to do. The good thing is that most of the time, in the first trimester, the baby is going to get what it needs. It's just taken from you. And that's why you might see some people even losing weight from the nausea and vomiting in pregnancy or hyperemesis. So, like you said, you have to look at the big picture instead of what that number is.
So I'm going to ask you this next question. And I mean, it ties in with what we're talking about, but just to flat out answer the women who ask this question is like, can they lose weight while pregnant? I cannot tell you. We get asked that question more often than I'd like to think about that, but we do. And, I mean, from, obviously, I know you already addressed, like for women who are,
Hmm.
really extremely
Hmm.
overweight, that might be a different conversation. But for,
No, no one should ever actively try to lose weight in pregnancy. That's not the time to do it.
right.
Okay, it's not. You're making a human, and for a couple of reasons. Number one, you're making a human. Number two, dieting, even when you're not pregnant, is stressful. And you're watching the scale and you're worried about you're going to do that while you're pregnant. It's not going to be healthy for multiple reasons. So no, I would never recommend someone starting to diet when they're pregnant. I've seen that happen before, and it's not a good a combination. Now, if you start entering the pregnancy, or you have a surprise pregnancy and you weren't at the weight that you normally are or what you wanted to be, and then you all of a sudden freak out, and I've seen that happen too. Uh, talk to the doc, ask to see a nutritionist, start working on healthy eating habits, get things back on track. But understand that you may have started at a higher weight, and you're still going to likely gain weight in pregnancy, and then after the baby is born, then you can address and get back to your ideal weight. But doing it while you're pregnant is not the best time to do it. Absolutely not.
Yeah, it's looking at what is the goal. The goal is to be healthy
Yeah.
for you
Hmm.
and for baby. I just wanted to
Hmm.
reiterate that
Hmm.
because sometimes
Yeah.
we have to we have to think about what else we need to focus on versus
Hmm.
like the scale, right?
Yeah. Yeah. Yeah.
So,
Hmm.
yeah.
I mean, I had a patient recently actually who uh she started at a higher weight, and the family that she lived with was also of a higher weight as well, and she got pregnant and she freaked out. She developed an eating disorder, and that happens in pregnancy too. And I don't think she intended to do that, but that's ultimately what happened, because she was so afraid of uh, um, gaining too much weight that she ended up losing a bunch of weight, and then she had complications in her pregnancy. So that's not healthy either. Actually, it's probably worse, to be honest with you.
Yeah.
To start dieting or potentially develop a disordered eating and lose too much weight. That's going to be more detrimental for the pregnancy than just trying to maintain the weight that you were at, and adjusting your dietary habits that way.
Yeah, and really just focusing on health.
Hmm.
And when we focus on health, it has this like such a positive effect on decreasing stress as well. Because
Hmm.
then you're really focusing on the positive outcome
Hmm.
versus on, something that just feels heavy and negative and all
Yeah.
that towards
Yeah.
you. And I know that's hard. I don't know if you have any other, suggestions. I know obviously, working with someone who can help you get on a good eating plan.
Hmm.
But yeah. So, and um, Dr. Shannon, do you
Hmm.
have anything else that you would like to share with our listeners? Well, really about anything we talked about, but specifically around, this advanced maternal, pregnancy age, any
Hmm.
advice? I know you were 42 when you had your
Hmm.
twins.
Hmm.
So you
Yeah.
personally,
Hmm.
went through it as well. So,
Hmm.
and I know we get a lot of moms that
Hmm.
are of that age. And so, yeah, I don't know if you have any other advice or tips or questions that come your way that are
Yeah,
commonly.
no, I think one of my biggest pieces of advice is this: you have to trust your obstetrical care provider. That should be the primary source for whatever information you're getting, whatever advice, whatever any kind of education regarding pregnancy. That should be your primary source. I'm on social media. It's probably how you found me, and I see so much bad information out there from people who have no business giving it. And the amount of people who are listening to this, it just boggles my mind. I feel like, I don't know if it's because there's just a baseline lack of trust of the provider, or they're just worried they're going to miss something, or somebody else knows something better and they want to do this and do that and follow it. And it can be overwhelming. And the next thing you know, you're listening to this Facebook group, this Instagram influencer, and you're never talking to your obstetrical care provider about what you're worried about. That should be where you first and foremost go to whenever you have an issue, when you have a problem, when you have a question. So that's why it's very important to really vet your providers and find someone that you like, and that you trust. Word of mouth is important for other people that have been to that provider and can vouch for them. So, you know, I was talking to someone the other day. I was like, we will get more estimates on a car repair from different body shops than we do about our own people that are taking care of us in our pregnancy.
Yeah.
You know, we're more worried about the quality of the body shop where we take our car than we are about who's taking care of us as pregnant. And we can do that. We can go through when we're early in pregnancy and figure out who we like and who we trust. There's nothing wrong with that. So, you know, I just want, you know, social media is great. It is. We all love social media, but there is a downside to it. And that's one of them. Just getting bad information. Just make sure that you trust your doc.
That's great advice.
Mm-hmm.
Communication, right?
Mm-hmm. Yeah.
Asking that why, asking those questions.
Mm-hmm.
That's so
Yeah.
important. So,
Mm-hmm.
well, Dr. Shannon, I know you are a contributor on the
Mm-hmm.
ACOG's new book, which I'll be,
Mm-hmm.
you know, helping promote on my social
Mm-hmm.
as well. It's loaded with
Mm-hmm.
so much
Mm-hmm.
information.
Yeah.
I have not read it front to back, but I have looked through it.
Mm-hmm. Mm-hmm. Mm-hmm.
It looks like an amazing guide for mamas. So,
Yeah.
and I also know you have your own website as well. So will you share with everybody where they can find more about, you know, you and the information that you
Mm-hmm.
share, as well as, you know, if they wanted to reach out to you on
Yeah.
social media?
Yeah. So my website is babiesafter35.com. I'm most active and interactive on my Instagram, Babies After 35. And then I also I have a TikTok account at TikTok Baby Doc, but I mainly use TikTok just to make the videos for Instagram. So yeah, I share most of what I do on TikTok on Instagram. But yeah, I think I'm most active for sure on Instagram.
I love it. Yeah, Instagram's kind of the easiest to be able to
Mm-hmm.
get on there and talk to people and
Yeah.
answer
Yeah.
questions that people ask and all that. So,
Mm-hmm.
well,
Yeah.
Dr. Shannon, this has been so great.
Mm-hmm.
You're so full of so much knowledge that I'm really excited that we got to chat today and
Mm-hmm.
help spread some more words of wisdom to all of our listeners. So, thank you.
Thank you. Thank you for having me.